The course ends where the patient begins. A resident does not need a floating list of trials. A resident needs a way to stand in front of a patient with a short cervix or a prior spontaneous preterm birth and know what kind of reasoning is required. Use this sequence. First, define the phenotype. Is this a singleton pregnancy? Is the patient asymptomatic? Are the membranes intact? Is there cervical dilation? Is there a prior spontaneous preterm birth? Is this one prior event or two? Were the prior births late preterm or very early? Is this a current short cervix without prior history? Or recurrence risk plus current cervical shortening? Second, define the timing. At what gestational age was the cervix measured? Before 24 weeks, the patient may resemble the strongest short cervix progesterone evidence. After 24 weeks, especially after 28 weeks, late initiation becomes a different evidence question. Third, define the endpoint. Are we trying to reduce birth before 37 weeks? Before 34? Before 33? Before 28? Are we trying to gain days from diagnosis to delivery? Are we trying to improve neonatal outcomes? Do not say early delivery unless you can name the endpoint. Fourth, map the patient to the evidence.
If she is asymptomatic, singleton, no prior spontaneous preterm birth, and the cervix is 20 millimeters or less before 24 weeks, the guideline-supported medical treatment is vaginal progesterone. If the cervix is 21 to 25 millimeters before 24 weeks, the decision is more preference-sensitive. If the cervix is first found short after 24 weeks, the evidence for starting treatment is weaker. If she has prior spontaneous preterm birth without short cervix, vaginal progesterone is not simply a replacement for 17-OHPC. Now, test the sequence with 3 patients. Patient 1, asymptomatic singleton pregnancy, no prior spontaneous preterm birth, cervical length 19 millimeters at 21 weeks. Phenotype, asymptomatic singleton, no prior preterm birth. Timing, before 24 weeks. Endpoint, prevention of early spontaneous preterm birth, especially before 34 or 33 weeks. Evidence match, strong. This patient is close to the clean short cervix progesterone evidence and the SMFM recommendation zone. The counseling can be confident, but still exact. The strongest evidence applies to patients like you, with a short cervix found before 24 weeks. Vaginal progesterone reduces early preterm birth in this phenotype. The recommendation is strongest at 20 millimeters or less. Patient 2, asymptomatic singleton pregnancy, no prior spontaneous preterm birth, cervical length 22 millimeters at 26 weeks.
Phenotype, asymptomatic singleton, no prior preterm birth. Timing, after 24 weeks. Endpoint, now time gained and prevention of later threshold births becomes central because some earlier endpoints are already passing. Evidence match, weaker. This is not the same patient as the first one. The cervical length is abnormal, but the initiation evidence has changed. Late initiation studies in no prior preterm birth populations have not shown clear reduction in spontaneous preterm birth or prolongation of pregnancy. A decision to treat, if made, should be described as uncertain or extrapolated rather than proven. Patient 3, singleton pregnancy, prior spontaneous birth at 28 weeks. Now a short cervix is found. Phenotype, recurrence risk plus current cervical shortening. Timing must be defined. Endpoint must be defined. This patient is not simply a short cervix patient and not simply a prior preterm birth patient. She is an overlap phenotype. Her recurrence history matters. McManamy taught that risk rises with number, order, and severity of prior preterm birth. If there are 2 prior very early preterm births, the recurrence risk can be much higher than with 1 remote late preterm birth, followed by a term birth. Her current cervical length adds a present tense risk signal.
For medical treatment, do not automatically reach for 17-OHPC. Current guidance does not recommend it. Do not automatically substitute vaginal progesterone if the cervix is normal. If the cervix is shortened, vaginal progesterone may be considered, but the full management conversation may also involve mechanical interventions that belong to a different course. Now compress the course into memory. 25 millimeters is the short cervix boundary, but not a biological cliff. 20 millimeters or less before 24 weeks is the strongest SMFM vaginal progesterone recommendation zone for the asymptomatic singleton without prior spontaneous preterm birth. Pregnant means 10 to 20 millimeters, 90 milligrams vaginal gel daily, and preterm birth before 33 weeks reduced from 16.1 to 8.9%. Fonseca means 15 millimeters or less, 200 milligrams vaginal progesterone nightly, and spontaneous delivery before 34 weeks reduced from 34.4 to 19.2%. Romero 2018 means the individual patient data synthesis. Fewer births before 33 weeks and mean gestational age at delivery about 0.74 weeks higher.
Mays means weekly intramuscular 17-OHPC for prior spontaneous preterm birth, with an initially positive result. Prolong means the confirmatory trial did not reproduce the benefit. Current guidance means 17-OHPC is not recommended, and vaginal progesterone is not its substitute unless a shortened cervix changes the phenotype. Late initiation means caution. Continuing a regimen that began in the evidence window is not the same as starting after the window. Einem shows a timing gradient. Dominski and the later asymptomatic cohort abstract do not show time gained after late diagnosis in lower risk populations. Finally, remember the endpoint discipline. Under 37 weeks, under 34 weeks, under 33 weeks, under 28 weeks, diagnosis to delivery interval, mean gestational age at delivery, and neonatal morbidity are not synonyms. A physician who knows the endpoint knows what kind of benefit is being claimed. The final bedside model is simple, but not simplistic. Classify the phenotype, locate the timing, name the endpoint, match the evidence. Then prescribe, decline, or counsel with the appropriate degree of certainty. That is how the details become useful. Not because they were memorized as isolated facts, but because they now form the structure of clinical judgment.